All right, so here we are at the fourth section of chapter 4. We're going to be focusing on treatment. I've had quite a few graphics to this last piece here to illustrate some of the treatment techniques. So the learning outcome is to describe evidence-based swallowing treatments for both children and adults. So your textbook has divided treatment approaches into three basic categories. We have compensatory strategies that are used to change the flow of the bolus. And so they're helpful when we use them, but they don't carry over and impact physiology per se. So they're helpful when we use them, but they don't change the way we swallow if we don't use them. And then we have indirect swallowing rehab approaches and direct swallowing rehab strategies. And I'll define those in just a minute here. So again, one of the big considerations is the environment with which people eat in. And so are there visual and auditory distractions that should be minimized? So should we turn off the overhead speakers, maybe create situations where there's less visual distractions so people with swallowing impairments can focus. You know, are they eating in front of the television? Is there a lot of conversation that's going on? These things can often impact function. Also, in terms of considering the environment, we need to consider the degree to which caregivers provide a supportive eating environment. And so are they trained? Are they relaxed? Do they take their time? It takes about 25 minutes to feed someone who is dependent for feeding. And so this often takes time and training. So the goal is the development of self-feeding skills or maximizing independence with self-feeding skills as much as possible. And having clients do this on their own is always recommended. And then we need to consider the utensils that are needed. So we have a bunch of different adaptive equipment that we might consult with our OT colleagues. And again, it needs to be age appropriate. So I wouldn't give a sippy cup, so to say, to someone who, like an adult with a traumatic brain injury. So we need to consider them and make modifications as needed. So now let's break down direct versus indirect swallowing treatments. And so first of all, everything that we consider for our interventions should be based and tried out in our clinical and instrumental assessments. So we need to consider the safety, appropriateness, and have practiced these things and have used our assessments to guide the selection of these techniques, as well as, of course, the patient's characteristics and their wishes and desires as well in patient-centered approaches. So some techniques are practiced without food and some are practiced with food. And so the direct ones are those that can be accomplished during swallowing, and so with food and liquids. And the indirect ones are typically exercises that there is some evidence and a theoretical basis to show that they'll carry over and improve swallowing function. So there's been a lot of work done in the last decade with tongue strengthening, and I'll give you some examples of laryngeal strengthening or strap muscles that we enhance to improve laryngeal elevation and the safety and efficiency of swallowing. All right, so let's start off with compensatory techniques, usually the first things that we consider. And so once again, an upright 90 degrees in the hips and the knees, symmetrical upright position is usually the recommended. So the head and neck must be positioned from making any sort of extraneous movements, and so they might need some supports. And the best position is usually fully upright and with the head flexed down slightly. So we'll often work with OT and our PT colleagues and use a team approach to maintain these positions. So perhaps the most tried and true technique is the chin tuck. And we use this for a couple reasons, and usually it's used with a delayed pharyngeal swallow. And so we have the client look downward, to flex their chin downward towards their chest. And essentially this creates an upward slope with the tongue so it doesn't spill over, the bolus doesn't spill over into the pharynx before it's ready to be triggered. There's also some evidence to show that when the head goes down, the epiglottis is pushed out, and it provides more of a protective mechanism. The head back position is used only in cases where there's excellent airway closure and protection, and it would be used with someone who had poor tongue motility. And so, like a glossectomy, if someone had their tongue removed, or so again, this typically used in head and neck cancer. Now, head tilt or head rotation is a common technique, and so this usually uses gravitation forces to have the bolus flow on the intact side and away from the impaired side. So again, with hemiparesis and paralysis, we often get one-sided weakness and lack of sensation, and so we try to coax the bolus to travel down the intact side. So all of these compensatory techniques require some degree of patient compliance, adequate cognition to follow through on the commands, and the physical capability to assume these postures and positions. Okay, so I had an illustrator a few years ago put together these slides for me. And so the first one is the chin tuck. So you see here, it creates an uphill gradient. So while the client is masticating semi-solids or has their lip closed with liquids, they're sort of getting ready, and this prevents things from spilling over. Once again, the epiglottis is pushed out here into a more protected position. Here in the middle of this slide is head rotation. And so we turn the basically turn the head to the side of weakness, and so that the path of the bolus will go down the strong side. So it sort of seals off that side by turning to this side of weakness. And then the head tilt is we would tilt the head to the stronger side of the body, and again, using gravitation. So this is often used when there's oral weakness, and a more common technique in head and neck cancer. So modifications of food and liquids is perhaps the most widely used technique, and there's a lot of criticism that these can have a real impact on people's lives. So before we mess with people's food consistencies and the texture of our food, we should probably consider compensatory techniques and other direct and indirect treatments, because this has a real bearing on satisfaction with meal times. So foods that are hard to chew, that are small or very sticky, are not recommended with folks who have neuromuscular difficulties. So things like peas and rice that fall apart can be challenging. So we recommend that they add gravies and sauces for them to come together. Dried meat like beef jerky or dried meat products are notoriously culprits in obstructing the airway. So we make sure that those are ground up or chopped up. And again, things that are moist slide through. So clients that cannot tolerate any food by mouth, and we call that MPO, or so that happens sometimes, may only accept thick liquids or thin liquids, and certain disorders like esophageal disorders, with more severe esophageal disorders, we often go to a liquid diet. And in some cases, clients may require a pureed consistency, although this can be not that palpable or appealing. And so again, this is sort of the last resort. So our goal is to keep food as close to normal as possible. So what I have here is a graphic on the top, and this is what a pureed diet looks like. It's blenderized and it has gravies and sauces. So one of the big challenges is carbohydrates. And so there's typically no bread products in a pureed diet, or they'd have to be completely soaked. Okay, so this is a pureed meal, and here's the same meal, and this would be the regular texture. So as we move from pureed to regular, there's two steps, and this is the National Dysphagia Diet Task Force has worked on these levels, and we've got many descriptors to help guide healthcare practitioners and dietary staff to have consistent application of these principles. So with mechanical diets, these things that are usually chopped or ground up, and often will have sauces and gravies. And then the advanced is one step below a normal diet, would exclude things like raw carrots and seeds and other and sort of mixed, sometimes mixed consistencies. So there's a variety of things that are not recommended in the advanced diet, where in a regular diet would be the diet that you and I would eat. Now with liquids, the convention is to describe them by their consistency. And so thin liquids would be like water, nectar, or nectar thick would be the same consistency of like tomato juice or like apricot nectar. And we put thickener or often starch-based thickeners into drinks to make them heavier, and it gives more feedback and a little easier to control. And again, the honey consistency is honey-like, and it sort of doesn't roll off a spoon so much. And then spoon thick would be the same consistency as pudding. So we also modified the delivery of foods. And so for many individuals, drinking through a straw can cause too much fluid to enter the mouth or the oral pharynx. Sometimes we'll use larger bore straws or shorter straws and play around with the straws. And so that's a major consideration, is whether or not a straw is helpful. Sometimes we will use smaller spoons or adaptive equipment. We'll often avoid placing food in the mouth until the bolus has been swallowed previously. Patients are often encouraged to do a second dry swallow to clear, or a second sip and swallow to clear the pharynx before taking another one. And as I had shared with you in the case study, we often manipulate temperatures and consistency. So cold textures tend to be easier to swallow. Carbonated beverages seem to be easier to swallow than non-carbonated. Sometimes tart lemon bolus is used intermittently every 4 or 5 swallows to enhance the sensory feedback. And once again, the placement of the bolus should be in the side with intact sensation. Okay, so moving on to the next category, and this is something that's gained a lot of acceptance and evidence base in the last decade or so, is the role of exercise in swallowing. So we look to principles of exercise physiology, and in the graduate level coursework, we spend quite a bit of time discussing how we have to enhance the intensity, we have to make certain adaptations, and that whatever exercise should reflect sort of the real world demands of these physiological acts. So bite blocks can be encouraged to lower the mandible. We'll use flavored gauze pads and toothed to stimulate tongue and lip movement. We might facilitate laryngeal elevation and movement by placing our fingers on the thyroid notch and moving it upward. We do lip seal training by holding a tongue depressor with the lips, or sometimes with buttons. As the buttons get smaller, it gets more challenging, and we'll put them on like a string or dental floss and have the client pull against resistance. Tongue coordination is improved in a variety of techniques, and so we have the IOP, is a Iowa pressure valve that can give you feedback, give the client biofeedback with how hard they're pushing against an air-filled bulb, or we push against a tongue blade. And then, as we'll see here in a bit, we also spend with certain clients, select clients, time strengthening the muscles underneath the chin and the strap muscles that attach to the hyoid bone. And so this would be, we have a variety of muscles that we strengthen there. But the idea is that we can get a more rapid and timely laryngeal elevation to close the larynx more fully. Okay, so an example of these laryngeal exercises, one of them is the Shakir exercise, where clients lie flat and they raise their head, sometimes against resistance. Often it's done for so we do 2 sort of sets where we'll do 30 seconds where they sustain, and then we do rapid ones every 1 second. So here's a client who had head and neck cancer that I had worked with, and she's demonstrating the Shakir technique for strengthening the laryngeal elevating muscles. So if we'll count out 30 seconds, and so I'll do it the way I did it.
Yeah, and actually, one of the keys to this for me was not to go too far. 'Cause as soon as you start firing off those bigger neck muscles, you're not working those inner ones, and so then you're not doing what I need the inner ones worked on. And so if I fire the big ones, then they just take over, and so it's not as effective. So I go less high. That's my excuse anyway.
We'll just, for the purposes of the video, we'll just go like 25 seconds. So we'll just go, here we go. Now I do my legs out. So we're focusing on here. You can put your fingers right here on these muscles and try to isolate them.
I don't miss you coming over every day.
So again, there was a client who had a 4-centimeter tumor taken out of her oral pharynx. In the beginning, she was on a puree diet, and she advanced over the course of 5 or 6 months to a full return to a regular diet. And she had done 60, 70 hours of head and neck strengthening, and we were able to sort of remodel her head and neck function to the point where she could function pretty much with regular textured diet and without calling attention and not being fearful at meal times. Okay, so another direct treatment of swallowing is effortful swallow or hard swallow. And I use this quite a bit. And so this is used when the tongue-based retraction doesn't adequately touch the posterior pharyngeal wall, or there's difficulty triggering the swallow. So the client is instructed to forcefully swallow, and I often get them to chase the tail of the bolus. And so they swallow and then squeeze behind the bolus as it goes down. Another very common technique is called the supraglottic swallow or the supraglottic swallow. And so this is where we teach voluntary closure of the vocal folds to reduce the depth and misdirection of the bolus during swallow. So the instruction is to breathe in, to hold their breath. They put a small amount of food or liquid, they swallow, and then before breathing again, they cough and clear so they have expiratory airflow that's going to sort of push out or blow out any airway encumbrance. Okay, so here is an example of the hard swallow. Again, we've got enhanced tongue-based retraction, enhances pharyngeal contractions, and it enhances sort of volitional control. And so we sort of commandeer the swallowing mechanism and generate a lot more forceful swallow. So that's one that I use quite a bit. And again, that's something I would try out during video fluoroscopy to make sure that it's achieving what I think. Again, the supraglottic swallow is another tried and true technique. And so they take a pre-swallow breath hold, and so that the vocal folds are closed, they're holding their breath, they have extra air in, they swallow, cough and clear out, and then swallow and clear it down. Now in the supraglottic, this is where the degree of breath holding is more enhanced. So we get them to really bear down. And so this creates quite a bit of force. And so these techniques for individuals who have had stroke, we need to get medical clearance, because anytime you bear down this valsalva, you can have unstable drop in blood pressure. So there's some contraindications, particularly for the supraglottic swallow. So the Mendelssohn technique is another technique that's commonly used for people who can follow multi-step commands. And so this is done when we have reduced hyolaryngeal elevation. And so essentially we volitionally override the sort of more reflexive nature of the pharyngeal swallow. And the whole hyolaryngeal mechanism is held in an upright or elevated position for a couple seconds after the swallow. So the cues are: place a small amount of food or liquid in your mouth, chew, and then swallow, placing your thumb or forefinger on the sides of the larynx, either manually and eventually consciously and volitionally. You hold your larynx higher for 3 to 5 seconds. And essentially this keeps the upper esophageal sphincter wide open for an extended period of time. And so it allows the pharynx to drain. And then eventually the larynx drops and the patient inhales. And by then, or exhales, and by then any residue should have drained out. So here's the Mendelssohn. So what we'll notice here's the hyoid bone, a depiction of the hyoid bone that's basically held in an elevated position for a few seconds afterwards, with the goal of keeping the upper esophageal sphincter wide open and keeping the hatches battened down of the larynx. Okay, so moving on to medical and pharmacological approaches, many patients, especially with progressive neurological diseases, benefit from pharmacological interventions. So probably the most common is GERD or gastroesophageal reflux disease. And so if they take their proton pump inhibitors, if they do have backflow of stomach contents, it's much less acidic and much less likely to cause inflammation, swelling, and sort of precancerous changes in the tissues of the esophagus as well as the pharynx. Some medications can be done to alleviate dry mouth or xerostomia. It's very difficult to swallow without any saliva. And some medications may actually cause or contribute to swallowing disorders. So again, we've discussed those a little bit in the last section. So anti-seizure medications, medications that like Haldol or antipsychotics that make people not aware can also have a negative impact. There's also surgical and medical procedures that can be done to help the safety and efficiency of swallowing. So a palatal obturator is a device that can enhance velopharyngeal closure. Patients that don't have a tongue, so partial or complete glossectomy, where the tongue's been removed due to cancer, may benefit from a prosthesis. There's certain growths on the spine that can displace. So these are called osteophytes, common in older adults. And so like a bone spur that creates like a shelf or a wall in the pharynx and can cause issues. Certain surgical interventions can look at the vocal folds to enhance closure so they can be built up, or sometimes they inject material to give them more bulk. And then sometimes vocal folds in severe cases are completely sutured and closed, and a tracheotomy tube is placed below the vocal folds in cases where, severe cases where they can no longer protect their airway. So now your textbook has a brief review of non-oral feedings. And so a short-term solution would be an NG tube or a nasogastric tube. This is placed through the nose and down into the stomach. We have a depiction of it here. After a month to 6 weeks, these can become pretty uncomfortable. So it's usually a short-term solution. They're probably the best practice and most common technique has been a type of gastrostomy called a PEG tube. This is a percutaneous endoscopic gastrostomy, and it's placed through a hole in the abdomen right into the stomach. And this is usually if we suspect someone's going to have a long-standing swallowing issue. And I'm not going to go into total PPN and TPN, but these are short-term solutions for maintaining hydration. Okay, so in terms of wrapping up this section, treatment effectiveness and outcomes are a really important consideration. And so our aim is to improve food and drink and to prevent aspiration. And the success of this is determined by the cause, and so the etiology and the differential diagnosis, the severity and the onset, and whether it's a progressive disorder, whether, so the nature of the disorder has a big bearing. We try to identify as early as possible and intervene to prevent small grade aspiration from progressing to full-blown pneumonia. So we get these interventions in a timely way. Timely interventions shorten hospital stay, so length of stay, and has been shown to improve quality of life. And so caregivers and children who are at risk are instructed in feeding techniques as soon after birth, just to promote more normal development and prevent the certain compensatory techniques that can get in the way. And then with elderly clients, swallowing disorders are often related to poor dentition, particularly poor oral hygiene, and can be corrected with dental care. And overly restrictive diets. So if we place people on puree diets and don't consider other options and techniques and approaches, it often has a negative impact on quality of life. So we try to liberalize these diets as much as possible and try to make them closer to normal as much as possible. So in terms of the big wrap up here for chapter 11, SLPs work with infants who are unable to nurse adequately, children with feeding problems, as well as older adults. So this breakdown can occur in one of the 4 stages, could be impaired. We haven't spoken too much about the esophageal phases. And so again, SLPs tend to, by nature of our training, specialize in oropharyngeal stages. We know that swallowing impairments impact nutrition, health, social engagement, and personal aspects of health. It's always recommended to work in a team. These are complex disorders, high-risk patients, and so even though SLPs often take the lead with dysphagia, we work very closely with dietitians, OTs, and the rest of the medical team. Treatments need to address the feeding environment, so we try to manipulate the environment as well as the client. So the first things we consider is client posture, and then specific techniques, and probably the last thing we manipulate is food textures and liquid consistencies. And for some clients, non-oral feedings may be required either permanently to mitigate, and some clients will go on to eat for pleasure, small amounts, and sometimes they remain NPO and don't have any food. So this is a part of our differential diagnosis where we'll come back. So again, this is the wrap up for chapter 11, and thanks for your time with this.